Lewis's Medical Surgical Nursing, 11th edition. Chapter 39, Nutritional Problems. This chapter focuses on problems related to nutrition. A review of normal nutrition provides a basis for evaluating nutritional status. We need sufficient energy, protein, and other nutrients to maintain health. Many problems affect nutrition by changing the way we ingest, absorb, digest, and metabolize nutrients. These changes can lead to malnutrition and health problems which affect functional status and quality of life. This makes it important for nurses to incorporate assessment and interventions aimed at promoting optimal nutrition. Nutritional problems. Nutrition is the sum of processes by which one takes in and uses nutrients. We view nutritional status on a continuum from undernutrition to normal nutrition to overnutrition. Any change in nutrient intake or use can cause nutritional problems. Nutritional problems occur in all ages, cultures, ethnic groups, and socioeconomic classes, and across all educational levels. Many factors influence nutritional status. A person establishes attitudes toward food and eating habits early. Dietary intake often reflects cultural or religious preferences. A person or family's financial status influences the type and amount of nutritious food they can buy. Normal nutrition. Nutrition is important for energy, growth, and maintaining and repairing body tissues. Optimal nutrition, in the absence of any underlying disease process, results from eating a balanced diet. The major components of the basic food groups are macronutrients, carbohydrates, fats, proteins, micronutrients, vitamins, minerals, electrolytes, and water. Optimal nutrition and daily physical activity are essential for a healthy lifestyle. Body type, age, gender, medications, physical activity, and the presence or absence of disease influence a person's daily caloric requirements. Adjustments in caloric intake are necessary depending on changes in health status and daily activity level. There are several ways to estimate caloric need. The Mifflin-St. Jeor equation calculates daily adult energy calorie requirements based on resting metabolic rate. A simpler way to estimate daily calories needed is by kilocalories per kilogram. An average adult should consume 20 to 25 calories per kilogram body weight to lose weight, 25 to 30 calories per kilogram to maintain body weight, and 30 to 35 calories per kilogram to gain weight. Energy needs may be greater during illness. Carbohydrates, the body's main source of energy, yield about 4 calories per gram. We classify them as either simple or complex, depending on the number of sugars they have. Simple carbohydrates come in two forms: monosaccharides, e.g. glucose, fructose, which are found in fruits and honey, and disaccharides, e.g. sucrose, maltose, and lactose. They are found in foods such as table sugar, malted cereal, and milk. Complex carbohydrates, polysaccharides, include starches such as cereal grains, potatoes, and legumes. Carbohydrates are the chief protein-sparing ingredient in a nutritionally sound diet. The Dietary Reference Intake (DRI) recommendations are that 45 to 65% of total calories should come from carbohydrates. A person should take around 14 grams of dietary fiber per 1,000 calories eaten per day from fruits, vegetables, and whole grains. This equals roughly 28 to 30 grams for a typical 2,000 calorie diet. We should choose food and beverages with little added sugar or caloric sweeteners. Fats are a major source of energy for the body. 1 gram of fat yields 9 calories. Fats are stored in adipose tissue and the abdominal cavity. They act as carriers of essential fatty acids and fat-soluble vitamins. Fats give us a feeling of satiety after eating. Fat intake should be no more than 20 to 35% of total calories. Fats can be divided into 1, potentially harmful, saturated fat and trans fat, and 2, healthier dietary fat, monounsaturated and polyunsaturated fat. One type of polyunsaturated fat, omega-3 fatty acids, may be especially beneficial to your heart. Omega-3 fatty acids, found in some types of fatty fish, appear to decrease the risk for coronary artery disease. Diets high in excess calories, usually in the form of fats, contribute to the development of obesity. We should consume less than 10% of calories from saturated fatty acids, about 20 grams of saturated fat per day in a 2,000 calorie diet, and choose foods with no trans fatty acids. Proteins are an essential part of a well-balanced diet. They are needed for tissue growth, repair, and maintenance, body regulatory functions, and energy production. Ideally, 10% to 35% of daily caloric needs should come from protein. The recommended daily protein intake is 0.8 to 1 gram per kilogram of body weight. For the normal healthy person of average body size, this equals about 45 to 65 grams of protein daily. 1 gram of protein yields 4 calories. Amino acids are the fundamental units of protein structure. We classify the 22 amino acids as essential or non-essential. The body can make non-essential amino acids if an adequate supply of protein is available. The body cannot make the 9 essential amino acids. Their availability depends totally on dietary sources. We obtain them from both animal and plant sources. Complete proteins contain all the essential amino acids. Proteins that lack one or more of the essential amino acids are incomplete proteins. Table 39.2 lists foods high in protein. Vitamins are organic compounds needed in small amounts for normal metabolism. Vitamins function primarily in enzyme reactions that facilitate amino acid, fat, and carbohydrate metabolism. A diet consisting of foods from the 5 basic food groups is essential for obtaining the recommended dietary allowances of essential vitamins. Vitamins are divided into 2 categories: water-soluble vitamins, vitamin C and the B complex vitamins, and fat-soluble vitamins, vitamins A, D, E, and K. Since the body stores excess fat-soluble vitamins, consuming too much can result in toxicity. There are upper limits for vitamins A, D, and E. Mineral salts, e.g. magnesium, iron, calcium, make up about 4% of the total body weight. The body needs minerals to build and repair tissues, regulate body fluids, and assist in various functions. Minerals needed in amounts greater than 100 milligrams per day are major minerals. Minerals present in minute amounts are trace elements. Table 39.3 lists the major minerals and trace elements. Some minerals are stored and can be toxic if taken in excess amounts. The amount of minerals needed daily varies from a few micrograms of trace minerals to 1 gram or more of the major minerals, such as calcium, phosphorus, and sodium. A well-balanced diet usually meets the daily requirements of minerals. However, deficiency and excess states can occur. Vegetarian diet. There are many types of vegetarians and no strict definition of the word vegetarian. The common element among all vegetarians is the exclusion of red meat from the diet. Many vegetarians are vegans, who are pure or total vegetarians and eat only plants, or lacto-ovo vegetarians. They eat plants, dairy products, and eggs. Without a well planned diet, vegetarians can have vitamin or protein deficiencies. Plant protein, although a lesser quality than animal protein, fulfills most protein requirements. Combinations of vegetable protein foods, e.g., cornmeal, kidney beans, can increase the nutritional value. Milk made from soybeans or almonds is an excellent protein source and should be calcium fortified. Vegans and lacto-ovo vegetarians are also at risk for iron deficiency. Table 39.4 lists examples of food high in iron. The primary deficiency for a strict vegan is lack of cobalamin, vitamin B12. We obtain cobalamin from animal protein, special supplements, or foods fortified with the vitamin. Vegans not using cobalamin supplements are susceptible to the development of megaloblastic anemia and the neurologic signs of cobalamin deficiency. Other deficiencies that may be present in a vegan diet include calcium, zinc, and vitamins A and D. Culturally competent care, nutrition. People have unique cultural heritages that may affect eating customs and nutritional status. Each culture has its own beliefs and behaviors related to food and the role that food plays in the cause and treatment of disease. Culture and religion can influence which foods are considered edible, how they are prepared, when they are eaten, and how and who prepares them. For example, some religions, such as Judaism and Islam, have specific laws about food. Assess the extent to which Jewish or Muslim patients adhere to kosher or halal dietary practices to ensure that we serve proper meals. The websites Kosher Quest and the Islamic Food and Nutrition Council of America provide detailed information. Assess the patient's diet history and implement needed dietary changes. Avoid cultural stereotyping by not making assumptions or generalizations about diet based on a person's cultural background. Dietary habits differ considerably within and among ethnic groups. Acculturation, the process by which immigrants adopt the lifestyle of a new culture, can affect dietary practices. It is important to know whether the patient eats traditional foods associated with the culture. Assess the impact of eating traditional foods on health. For example, traditional foods eaten by some Asian Americans may be high in fiber and low in fat and cholesterol. The diet may be low in calcium because of limited dairy product intake. Soul food, identified with some blacks, includes foods such as collard greens and vegetables prepared with pork, beans, fried meats, grits, and cornbread. This diet may increase the risk for diabetes and heart disease. Considering cultural beliefs is important when planning and monitoring acceptance of dietary changes. Culture can influence the perception of body weight and size. Ask the patient or family about how culture affects dietary choices and weight maintenance. For example, in some cultures, obesity does not carry the stigma that it does in Western cultures. This may make teaching about weight reduction harder. A Jewish patient who eats only kosher food may find comfort in knowing that an enteral feeding formula is kosher. Another example of culturally sensitive planning is adjusting meal plans for the Muslim patient observing Ramadan, the Islamic month of fasting, in which Muslims refrain from eating and drinking during daylight hours. Malnutrition. Malnutrition is a deficit, excess, or imbalance of essential nutrients. It may occur with or without inflammation. Malnutrition affects body composition and functional status. Other terms used to describe malnutrition include undernutrition and overnutrition. Undernutrition occurs when nutritional reserves are depleted and nutrient and energy intake are not sufficient to meet daily needs or added metabolic stress. Overnutrition refers to the ingestion of more food than is required for body needs, as in obesity. Malnutrition is a problem in both developing and developed countries across the care continuum: community, hospital, long term care. Prevalence rates for malnutrition in the hospital setting range from 30 to 50%. The prevalence of malnutrition in older adults, based on the Mini Nutritional Assessment (MNA), ranges from about 3% community dwelling older adults to 30% rehabilitation settings. Etiology. Several terms describe the types and causes of adult malnutrition. Older terms still used in some settings include primary or secondary protein calorie malnutrition, PCM, marasmus, and kwashiorkor. Marasmus and kwashiorkor describe forms of malnutrition seen in children in developing countries. You should not use these terms to describe malnutrition in adults. The following cause-based terms are the preferred ones to use in clinical practice settings, since they indicate the interaction and importance of inflammation on nutritional status. Starvation-related malnutrition, or primary PCM, occurs when nutritional needs are not met. In primary PCM, there is chronic starvation without inflammation, e.g. anorexia nervosa. Chronic disease-related malnutrition, or secondary PCM, is related to conditions that have sustained mild to moderate inflammation. This occurs when dietary intake does not meet tissue needs, although it would under normal conditions. Examples of conditions associated with this type of malnutrition include organ failure, cancer, rheumatoid arthritis, and obesity. Acute disease-related or injury-related malnutrition is related to acute disease or injury states with marked inflammatory responses, e.g. major infection, burns, trauma, surgery. Contributing factors. Many factors contribute to the development of malnutrition, including socioeconomic factors, physical illnesses, incomplete diets, and drug-nutrient interactions. Table 39.5 lists conditions that increase the risk for malnutrition. Socioeconomic factors. Persons or families with limited financial resources may have food insecurity, inadequate access. Food insecurity is a major public health problem. It affects the overall quality of food that is available in both quantity and nutritional value. Those with food insecurity usually choose less expensive filling foods, which are more energy dense, high fat, and lack nutritional value. This type of diet increases the risk for nutrient deficiencies. To help obtain food, people may use safety net programs. These include food assistance programs, housing and energy subsidies, and in-kind contributions from relatives, friends, food pantries, or charitable organizations. Consult with social workers to help patients gain access to government and local programs, such as Meals on Wheels that deliver nutritious meals to homebound people. The heat or eat phenomenon is problematic, as those with limited economic resources struggle to pay household utility bills or put food on the table. Older adults on a fixed income have an added burden of deciding on whether to pay for medications or food. You and the dietitian can help patients in making food choices that meet nutritional requirements while staying within their limited resources. Physical illnesses. Malnutrition is a common consequence of illness, surgery, injury, or hospitalization. The hospitalized patient, especially the older adult, is at risk for becoming malnourished. Prolonged illness, major surgery, sepsis, draining wounds, burns, hemorrhage, fractures, and immobilization can all contribute to malnutrition. Undernutrition can worsen a pathologic condition. An existing deficiency state is likely to become more severe during illness. Anorexia, nausea, vomiting, diarrhea, abdominal distension, and abdominal cramping may accompany gastrointestinal (GI) disease. Any combination of these symptoms interferes with normal food consumption and metabolism. In addition, a patient may restrict intake to a few foods or fluids that may not be nutritious out of fear of worsening an existing GI problem. Malabsorption syndrome is the impaired absorption of nutrients from the GI tract. Decreases in digestive enzymes or in bowel surface area can quickly lead to a deficiency state. Many drugs have undesirable GI side effects and alter normal digestive and absorptive processes. For example, antibiotics can change the normal flora of the intestines. This decreases the body's ability to make biotin, a B complex vitamin whose production depends on that gut flora. Fever accompanies many illnesses, injuries, and infections, with a concomitant increase in the body's basal metabolic rate, BMR, and nitrogen loss. Each degree of temperature increase on the Fahrenheit scale raises the BMR by about 7%. Without an increase in caloric intake, the body uses protein stores to supply calories and protein depletion develops. After the body temperature returns to normal, the rate of protein breakdown and resynthesis may stay increased for several weeks. Consider the nutritional requirements of a patient who is not overtly ill, but having diagnostic studies. This patient may be nutritionally fit on entering the hospital, but can become malnourished because of the dietary restrictions imposed by multiple diagnostic studies. Incomplete diets. Vitamin deficiencies are rare in most developed countries. When vitamin imbalances do occur, they usually involve several vitamins rather than a single one. This may happen with a person with a pattern of alcohol and drug use, those who are chronically ill, and those who follow poor dietary practices. Persons who had surgery on the GI tract may be at risk for vitamin deficiencies. For example, resection of the terminal ileum poses a risk for deficiencies of fat-soluble vitamins. After a gastrectomy, patients need cobalamin supplements. Because intrinsic factor, normally made in the stomach, is not available to bind with cobalamin, cobalamin cannot be absorbed in the ileum. Followers of fad diets or poorly planned vegetarian diets are also at risk. Manifestations of vitamin imbalances range from skin conditions to neurologic signs. The recommended dietary allowances for essential vitamins and manifestations of imbalances are outlined in Table 39.6. Drug-nutrient interactions. A drug-nutrient interaction occurs when a drug affects the use of nutrients in the body. Many drug and food or beverage interactions may occur. Potential adverse interactions include incompatibilities, altered drug effectiveness, and impaired nutritional status. Many drugs have side effects, such as changes in taste, appetite, and nausea. Grapefruit juice can increase the absorption of some drugs, enhancing their effect. Drug-nutrient interactions can also occur with the use of herbs and dietary supplements. Monitor and prevent these potential interactions for patients in the hospital and at home. Pathophysiology of starvation. Knowing the pathophysiology of the starvation process will help you understand the physiologic changes that occur in malnutrition. Initially, the body selectively uses carbohydrates, glycogen, rather than fat and protein to meet metabolic needs. These carbohydrate stores, found in the liver and muscles, are minimal. They may be totally depleted within 18 hours. During the early phase of starvation, protein is used only in its normal participation in cellular metabolism. However, once carbohydrate stores are depleted, the body converts skeletal protein to glucose for energy. Alanine and glutamine are the first amino acids used in gluconeogenesis, the process by which the liver forms glucose. The resulting plasma glucose allows metabolic processes to continue. When these amino acids are used as energy sources, the person may be in negative nitrogen balance. Nitrogen excretion exceeds nitrogen intake. Within 5 to 9 days, the body uses fat to supply much of the needed energy. In prolonged starvation, fat provides up to 97% of calories, conserving protein. Depletion of fat stores depends on the amount available. Fat stores are generally used up in 4 to 6 weeks. Once fat stores are gone, the body uses visceral and body proteins, including those in internal organs and plasma. They rapidly decrease because they are the only remaining body sources of energy available. If a malnourished patient has surgery, physical trauma, or an infection, the stress response is superimposed on the starvation response. The body uses protein stores for energy to meet the increased metabolic energy expenditure. As protein depletion continues, liver function becomes impaired and protein synthesis decreases. The decrease in protein synthesis lowers plasma oncotic pressure. A major function of plasma proteins, primarily albumin, is to maintain the osmotic pressure of blood. When the oncotic pressure decreases, body fluids shift from the vascular space into the interstitial compartment. Eventually, albumin leaks into the interstitial space along with the fluid. Edema becomes observable. Often, edema in the patient's face and legs masks the underlying muscle wasting. As the total blood volume decreases, the skin appears dry and wrinkled. As fluids shift to the interstitial space, ions also move. Sodium, the main extracellular ion, increases in amount within the cell. Potassium, the main intracellular ion, and magnesium shift to the extracellular space. The sodium-potassium exchange pump has high energy needs, using 20 to 50% of all calories ingested. When the diet is extremely deficient in calories and essential proteins, the pump will fail. This leaves sodium inside the cell, along with water, and the cell expands. The liver is the body organ that loses the most mass during protein deprivation. Fat gradually infiltrates the liver due to decreased synthesis of lipoproteins. Death will rapidly ensue if the person does not receive dietary protein and necessary nutrients. Impact of inflammation. Inflammation affects nutrient metabolism and is an important part of nutritional status. During the starvation process, there is a decreased BMR, sparing of skeletal muscle, and decreased protein breakdown. However, in inflammatory states, there are changes in the expression of pro-inflammatory, e.g. interleukin-6, and anti-inflammatory cytokines, e.g. IL-10. These cytokine changes result in increased protein and skeletal muscle breakdown, increased BMR, increased glucose turnover, decreased negative acute phase protein, albumin, prealbumin production, and increased positive acute phase protein, e.g., C-reactive protein, CRP, production. Clinical manifestations and diagnostic studies. The manifestations of malnutrition range from mild to emaciation and death. The most obvious signs are seen in the skin: dry and scaly skin, brittle nails, rashes, hair loss. Mouth, crusting and ulceration, changes in tongue. Muscles, decreased mass and weakness. And CNS, mental changes such as confusion, irritability. The speed at which malnutrition develops depends on the quality and quantity of the protein intake, caloric value, illness, and person's age. The manifestations result from numerous interactions at the cellular level. As protein intake declines, the muscles, the largest store of protein in the body, become wasted and flabby. This leads to weakness and fatigability. Decreased protein is available for tissue repair, causing delayed wound healing. The person is more susceptible to infections. Both humoral and cell-mediated immunity are deficient. Leukocytes decrease in the peripheral blood. Impaired phagocytosis occurs because of the lack of energy needed to drive the process. Many malnourished persons are anemic because they lack iron and folic acid, necessary building blocks for red blood cells. The diagnosis of malnutrition is best determined by body composition, including a thorough history of weight loss, nutrient intake, and measures of functional status. Obtain vital signs, height, and weight. Assess and document the patient's physical state and each body system. Table 39.7 outlines the assessment and findings of the patient with malnutrition. Laboratory studies. Serum albumin has a half-life of 20 to 22 days. In the absence of marked fluid loss, e.g. from hemorrhage or burns, the serum albumin value lags behind actual protein changes by more than 2 weeks. This makes albumin a poor indicator of acute changes in nutritional status. Prealbumin, a protein made by the liver, has a half-life of 2 days. It is a better indicator of recent or current nutritional status. However, the extent to which visceral proteins, including albumin and prealbumin, are true markers of malnutrition is questionable. Albumin and prealbumin are negative acute phase proteins. This means that during an inflammatory response, the liver decreases synthesis of these proteins. So low or below normal levels of albumin and prealbumin may indicate an inflammatory state rather than accurately depicting nutritional status. One way to determine if low albumin and prealbumin levels are due to malnutrition is to measure CRP, a positive acute phase protein. CRP typically increases during inflammation. A high CRP and low albumin or prealbumin suggest that inflammation is driving the change in albumin and prealbumin levels. Serum electrolyte levels reflect changes taking place between the intracellular and extracellular spaces. The serum potassium level often increases. The RBC count and hemoglobin level indicate the presence and degree of anemia. The total lymphocyte count decreases with malnutrition. Calculate it by multiplying the percent of lymphocytes times the total white blood cell WBC count. Liver enzyme levels may increase with malnutrition. Serum levels of both fat-soluble and water-soluble vitamins usually decrease. Low serum levels of fat-soluble vitamins correlate with the presence of steatorrhea, fatty stools. Nursing and interprofessional management, malnutrition. Nursing assessment. As a nurse, you are responsible for nutritional screening across care settings. Nutritional screening identifies those who are malnourished or at risk for malnutrition. The Joint Commission requires nutritional screening for all patients within 24 hours of admission, with a detailed nutrition assessment if a patient is at risk. Following a standard approach to nutritional screening, using valid and reliable tools will accurately identify those at risk. Many nutritional screening and assessment tools are available. Hospital-specific screening tools review common admission assessment data, including history of weight loss, intake before admission, use of nutritional support, chewing or swallowing issues, and skin breakdown. The Malnutrition Universal Screening Tool, Figure 39.3, and Nutrition Risk Screening are common tools used with adults in acute care. The MNA assesses nutritional status in older adults. In long-term care, the minimum data set, MDS, form is used to obtain nutrition information. In home care settings, the Outcome and Assessment Information Set, OASIS, is used to collect information on diet, oral intake, dental health, swallowing problems, and any need for meal assistance. If screening identifies a person at nutritional risk, perform a full nutritional assessment. A nutritional assessment is a comprehensive approach that includes medical, nutritional, and medication histories, physical examination, anthropometric measurements, and laboratory data. Nutritional assessment provides the basis for nutritional intervention. Obtain a complete diet history from the patient or caregiver. Assessing the foods eaten over the past week reveals a great deal about the patient's diet habits and knowledge of good nutrition. Often the patient's nutritional state is not the reason for seeking medical care. However, it may be a contributing factor to the disease and have an impact on management and recovery. Anthropometric measurements. Obtain height, weight, and girth measurements. Calculate the body mass index, BMI. We often use waist circumference and hip to waist ratio to assess nutritional status. Chapter 40. Obtaining accurate measures of weight and height are critical. When possible, measure the patient's actual height rather than using the patient's self-report. Alternatives to standing height, stature measurements include arm demispan and knee height measurements. The arm demispan is the distance from a point on the midline at the suprasternal notch to the web between the middle and ring fingers with the arm horizontally outstretched. For persons confined to bed, using a luft ruler is an alternative to standing height. When assessing weight, obtain a detailed weight history, noting weight loss. Ask whether the weight loss was intentional or unintentional and the period over which it took place. A loss of more than 5% of usual body weight over 6 months, whether intentional or unintentional, is a critical indicator for further assessment, especially in the older adult. If an involuntary weight loss exceeds 10% of the usual weight, determine the reason. Unintentional weight loss is important to consider in the obese person. Latent malnutrition may be present despite excess body weight. Determine the patient's current weight in relation to ideal body weight. Body mass index, BMI, is a measure of weight for height. A BMI of less than 18.5 is considered underweight. Normal weight is a BMI between 18.5 and 24.9, and overweight is a BMI between 25 and 29.9. A BMI of 30 or greater is obese. BMIs outside the normal weight range are associated with increased morbidity and mortality. Measure skin fold thickness at various sites, indicators of subcutaneous fat stores, and mid-arm muscle circumference, indicator of protein stores. The sites most reflective of body fat are those over the biceps and triceps, below the scapula, above the iliac crest, and over the upper thigh. The measures obtained are compared with standards for healthy persons of the same age and gender. Both skin fold thickness and mid-arm circumference may decrease in malnutrition. Shifts in hydration status influence these measurements. These measurements are most beneficial when done serially and by persons trained in anthropometry. Functional measurements. Functional assessment focuses on performance of activities of daily living, ADLs, tools. The tools used most often are the CATS index and Lawton scale. Measuring muscle strength can assess physical functional status, an important outcome of nutrition status. Hand grip strength is measured with a hand dynamometer. Timed gait and chair stands are markers of lower extremity strength. Nursing diagnoses. Nursing diagnoses for the patient with malnutrition include impaired nutritional status, impaired nutritional intake, fluid imbalance, risk for impaired tissue integrity. Planning. The overall goals are that the patient with malnutrition will 1. Achieve an appropriate weight, 2. Consume a specified number of calories per day on an individualized diet, and 3. Have no adverse consequences related to malnutrition or nutritional therapies. Nursing implementation. Health promotion. It is part of your role to teach and reinforce healthy eating habits. Use MyPlate, the dietary guidelines for Americans, and nutrition facts, food labels, to promote healthy nutrition. The MyPlate approach is a visual guide for sensible meal planning. It helps Americans eat healthfully and make good food choices. MyPlate focuses on the proportions of 5 food groups: grains, protein, fruits, vegetables, and dairy that you should eat at each meal. At the health professionals link at choosemyplate.gov, you can download daily food plans, sample menus, and tips for how to be physically active. These materials are valuable to use in patient teaching. MyPlate materials for older adults are available at blah 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 website. There are many resources to help people eat a nutritious diet and maintain a healthy weight. Electronic and print sources are available for determining nutritional information and commonly consumed foods. Many food products have nutrition fact labels. Consumer and health professional education materials on nutrition fact labels are available on the U.S. Food Drug Administration website. Help the patient find reliable internet sources that provide evidence-based food and nutrition recommendations. Interactive web-based programs and mobile device applications are available to track physical health, calories, nutrients, and foods eaten. Mobile device applications help with making healthy eating choices easier. Some use built-in barcode scanners to scan foods quickly and give individual food items nutrition facts. Users can compare items for their nutrition benefit and cost. Other applications give information on portion sizes and adjustments needed to reduce calories, sodium, or fat in the diet based on the user's height, weight, and activity level. Acute care. Collaborate with the HCP and dietitian to identify patients with malnutrition and implement appropriate interventions to meet the patient's nutritional needs. Assess nutritional state during your assessment of the patient's other physical problems. Identify risk factors for malnutrition and why they exist. With increased stress, such as surgery, severe trauma, and sepsis, patient needs more calories and protein. Wound healing requires increased protein synthesis. The patient having major surgery who is malnourished or is at risk for malnutrition needs several weeks of increased protein and calorie intake preoperatively to promote healing postoperatively. Teach the patient and caregiver the importance of good nutrition and the reason for recording the daily weight, intake, and output. Measure weight and height on admission, then routinely assess the person's weight. Daily weights give an ongoing record of body weight gain or loss. Rapid gains and losses are usually the result of shifts in fluid balance. Conjunction with accurate recording of food and fluid intake, body weight gives a clearer picture of the patient's fluid and nutritional state. If the patient can take food by mouth, obtain a daily caloric count and dietary to give an accurate record of food intake. You and the dietitian can help the patient and family in selecting high calorie and high protein foods unless medically contraindicated. Table 39.10 gives examples of high calorie, high protein foods. Offering foods preferred by the patient enhances intake. Encourage the family to bring the patient's favorite foods from home. Make sure the environment is conducive to eating. Provide a quiet environment. Offer oral hygiene and hand hygiene. Help the patient to a comfortable position and place the bedside table at the right height. Clear the bedside table of clutter. Place urinals, bedpans, and emesis basins out of sight. If needed, open cartons and packages. Protect mealtime from unnecessary interruptions by performing non-urgent care before or after mealtime. The undernourished patient usually needs to have between meal supplements. These may consist of items prepared in the dietary department or commercially prepared products. Eating these items provides extra calories, proteins, fluids, and nutrients. If the patient is unable to consume enough nutrition with a high calorie, high protein diet, consider adding oral liquid nutritional supplements. Some patients may benefit from appetite stimulants, such as megestrol acetate or dronabinol, marinol, to improve intake. Enteral nutrition, EN, may be an option in the patient who is still unable to take in enough calories. Contraindications for EN include GI obstruction, prolonged ileus, severe diarrhea or vomiting, and enterocutaneous fistula. If EN is not possible, consider starting parenteral nutrition, PN. Ambulatory care. Many patients are discharged on a therapeutic diet. Discharge preparation for both the patient and caregiver is essential. Teach them about the cause of the undernourished state and ways to avoid the problem in the future. They need to be aware that undernourishment, whatever the cause, can recur and that adhering to their diet for a few weeks cannot fully restore a normal nutritional state. It may take many months to reach this goal. Assess their ability to follow the dietary instructions considering past eating habits, religious and ethnic preferences, age, income, resources, and state of health. Emphasize the need for continual follow-up care to achieve and maintain rehabilitation. In your discharge planning, ensure proper follow-up, such as visits by the home health nurse and outpatient dietitian referrals. Determine the need for nutritious meals and snacks after discharge from the hospital. If access to a dietitian is limited, you may be the main source of nutritional information. In your assessment, consider the availability and acceptability of community resources that provide meals, such as Meals on Wheels, senior congregate feeding sites, and Supplemental Nutrition Assistance Program, SNAP. SNAP allows low-income households, regardless of age, to buy more food of a greater variety. Keeping a diet diary for 3 days at a time is one way to analyze and reinforce healthful eating patterns. These records are also helpful in the follow-up care. Encourage self-assessment of progress by having the patient weigh himself or herself once or twice a week and keep a weight record. Evaluation. The expected outcomes are that the patient who is malnourished will achieve and maintain optimal body weight, consume a well-balanced diet, has no adverse outcomes related to malnutrition, maintain optimal physical functioning. Gerontologic consideration. Malnutrition. Nutrition affects quality of life, functional status, and health in older adults. They are particularly vulnerable to malnutrition across care settings. You play a key role in assessing the physiologic, functional, environmental, dietary, psychologic, and social factors related to nutritional risk in older adults. Older hospitalized adults with malnutrition are more likely to have poor wound healing, pressure injuries, infections, decreased muscle strength, postoperative complications, and increased morbidity and mortality risks. They are less able to regain body weight after periods of undernutrition due to illness or surgery. Older adults may report little or no appetite, problems with eating or swallowing, inadequate servings of nutrients, and fewer than 2 meals per day. Limited incomes may cause them to restrict the number of meals or the dietary quality of meals eaten. Social isolation is a problem in older adults. Those who live alone may lose their desire to cook and report decreased appetite. Functional limitations may affect the ability to feed oneself, buy food, or cook and prepare meals. Some may lack transportation to buy food. Chronic illnesses associated with aging can affect nutritional status. For example, depression and dysphagia from a stroke can affect intake. Poor oral health from gum disease, missing teeth, or dry mouth can impair the ability to chew and swallow food. Medications can cause dry mouth, change the taste of food, or decrease appetite. Older adults with dementia or a stroke present unique nursing challenges regarding eating and feeding. Dementia is discussed in Chapter 59. Strokes are discussed in Chapter 57. Physiologic changes associated with aging include a decrease in lean body mass and redistribution of fat around internal organs, which can decrease caloric requirements. Sarcopenia, loss of lean body mass with aging, affects muscle strength and function. Older adults on bed rest or prolonged inactivity lose more lean body mass than younger adults. Changes in smell and taste from medications, nutrient deficiencies, taste bud atrophy can alter nutritional status. General nutrient requirements and healthy eating guidelines apply to older adults. Their requirements may vary depending on the degree of malnutrition and physiologic stress. To prevent loss of muscle mass and maintain function, older adults may need to increase their protein intake and ingest a moderate amount of high-quality protein at each meal. Daily vitamin D requirements are higher for older adults. Focus your initial care strategies on improving oral intake and providing a stimulating environment for meals. Special strategies such as use of adaptive devices, e.g., large handled eating utensils, often are helpful in increasing the patient's dietary intake. Some older adults may need nutritional support therapies until their strength and general health improve. Before starting any nutritional support therapy, e.g., EN, PN, for an older adult unable to give consent, review his or her advance directives about artificial nutrition and hydration. Malnourished or nutritionally at-risk older adults are vulnerable when discharged from the hospital to the home. Older adults may not be able to shop for or prepare foods during the initial recovery period. Consult with the social worker and dietitian to ensure the older adult has access to food on discharge. Home delivered meals or groceries or senior congregate feeding programs are an appropriate referral. Community nutritional programs can make mealtime a pleasant social event. Improving the social setting of a meal often improves dietary intake. Specialized nutritional support. If patients are unable to maintain or achieve adequate nutritional status, nutritional support may be needed. For a decision-making plan related to nutritional support, see Figure 39.6. Some agencies have nutritional support teams composed of a physician, nurse, dietitian, and pharmacist. The team's function is to oversee the nutritional support of select inpatients and outpatients. The nutritional support nurse on that team is a key resource for issues about patients' nutrition and nutritional access. Oral feeding. Oral supplements are widely used as an adjunct to meals and fluid intake in the patient whose nutritional intake is deficient. They provide advanced nutrition and calories and are relatively inexpensive. These include milkshakes, puddings, or commercially available products, e.g., Carnation Instant Breakfast and Sure Boost. Oral liquid supplements have a role in improving the nutritional status of older adults.